interesting topic, and then talk about all the issues that are relevant to the fertility world. We've got lots of live questions as well, and we answer all of those. So welcome to the show. We have a real interesting topic in a new study that hasn't been published yet to review, and so I'm hoping we'll have a great episode tonight. We had a camera glitch, so you're going to see me looking in two different directions, and I apologize for that, but I'll try and keep my eyes focused somewhere relatively in between. So hope you all had a great week. Hope everything is going well. Some super great news for us. We've got our initial approval from the College of Physicians and Surgeons of Ontario to do our IVF here. So it should be just a couple more weeks and we should be ready to go as we finalize all the documentation we need. But I want to thank them for an amazing inspection process. They were really happy with everything they saw. And so there's just a few final things we have to touch up to be all ready. And thanks to everyone for coming on board and watching. Hopefully you'll have some great questions for us tonight. I find this show is always really kind of an amazing opportunity to learn and to grow and to explain to everybody what we do and why we do it and so on. So if you have any interesting questions you want to share with us, don't hesitate. We will be happy to go through it all. Okay, so we usually allow everybody a minute or two to sign on. And we'll give everybody that chance. In the meantime, all the questions are still available and you can post them now, and then we'll get to them at the end. That has already happened several times. I'm not sure why. Is the battery good?
Must be the SD card.
Oh, it might be full or something?
No. It's not.
Glitching?
Yeah.
Okay. So you may have a shaky camera for a minute while we change the SD card. Go ahead and do it now. It won't stop everything, will it?
No, you'll keep going.
Yeah.
You're fine.
So we're just adjusting the camera for video capture, and we'll just deal with the technical glitches, like I said, and then we'll be ready to go. Yeah, that looks okay. All right, so the topic tonight is the differential impact of controlled ovarian hyperstimulation on live birth rate in fresh versus frozen embryo transfer cycles. That's a huge mouthful. So in English, what that means is there a difference with the dose of your stimulation, total dose, between fresh and frozen on the impact that it has on the cycle? And is it better to do a fresh or a frozen? And should you keep your doses lower or higher and so on? And they also actually looked at duration of stimulation, which we've reviewed previously and shown to be important, and many studies have. So the authors kind of cite a number of important studies here, and they say a lot of single center studies have shown that a long ovarian stimulation, especially more than 13 days, is detrimental with reduced pregnancy rates and live birth rates. And so we knew that. We've presented that on the show here. And a lot of people think that that's partially related to the high dose of gonadotropins that are used. So if you're using a very high dose, it's normally going to go longer as well, because it probably means the ovaries are weaker, so you need more stimulation to get the same kind of growth rate. And as a result, they're thinking that the success rates are not quite as good. They also say that the prolonged stimulation and the high dose of gonadotropins may impact the quality of the eggs and the embryos. And there are multiple studies that have shown that, about 7 in total that they've referenced here. So these guys wanted to look at a really big population and determine if that held true. So they have something in the US called SART, which is the Society for Assisted Reproductive Technology. And this is an agency that all US IVF centers must report their data to. And so they report their data to that center. They compile it for the whole country, and then people use that data to do research. So these guys took a fairly old population, 2014 to 2015, and during that time looked at 14,866 cycles that were fresh, 2,964 cycles that were frozen. Their criteria were that at least more than 90% of the embryos were blastocysts, and the patients ended up being relatively good prognosis patients because of that. So they really kind of looked at all of the different aspects to kind of get this to be a reasonable population of patients. So I'm just going to share the study with you. If you're watching on anything but Instagram, as usual on Instagram, it's impossible to follow. But I will go over the data with you here. Okay, so in the first table, the important thing you can see is that almost everything is statistically significant between the fresh and frozen group. But it's not really clinically significantly different. And the reason for that is anytime you're dealing with numbers in the thousands, even a small difference is statistically significant, but it's not actually clinically relevant. So for example, the difference in BMI between the two groups was 25.6 in the fresh, 24.8 in the frozen. Statistically significant, highly, but not clinically relevant. So that was all really true until they got down to diagnosis. When you looked at diagnosis, more people in the frozen group had PCOS, and that was significant, 26.8% versus 21.2%, so about a 5%, 5.5% increase. And then the same thing was true with AMH. They had a higher AMH level in the frozen group versus the fresh group. And then, of course, they had a higher yield of eggs and a higher yield of embryos in the group that was frozen. Now, interestingly, they had a very small difference in the spontaneous miscarriage rate in the fresh versus the frozen, with the fresh being a tiny bit less, 7.4% versus 10.4%. Live birth rate was clinically the same and actually statistically the same too, 45.1% in the fresh, 46.6% in the frozen. And that was not statistically different between the two groups. So you can see all that here in the study. Anything that's less than 0.05 is significant. So the first table they looked at was table 2. And in table 2, what they were looking at was a comparison of where does the total dose of gonadotropins that you use in your IVF cycle fall in relation to the outcome? And if you look at less than 1,000, 1,000 to 2,000, 2,000 to 3,000, and so on, with greater than 5,000 being the final group, the success rate decreases as you go up in dose. So at the less than 1,000, those patients had a 48.5% success rate with fresh, and a 50% success rate with frozen. But when you get into the, for example, 3,000 to 4,000 group, it's now down to 43% in the fresh and down to 42% in the frozen. Go up over 5,000 total units, and that's a lot. So you're using at least 500 units a day. It's 33.9% in the fresh, 37.7% in the frozen. So just to recalibrate that for you, if you're on Instagram especially, starting point was close to 50% or at 50% for the ones with the really low dose. And when you're getting into the really high doses, 33% and 37% fresh and frozen respectively. So a big difference in success rates, very highly significant. They did the same thing for duration of stimulation and essentially showed the same thing in both the fresh and the frozen groups. When you had a very short stimulation, you had a 47% success rate, 50% in the frozen group, and then it hovered kind of close to that, but then progressively drops off a small amount as you go up in your dose, suggesting that there may be an impact on the duration. Now, interestingly, in contrast to other studies, these guys used greater than 12 as a group. So this would be 13 days and more, whereas many of the studies have looked at greater than 13 days. And we certainly never go 13 days because there are enough studies that have shown that it is detrimental going that long. When you look at further evidence on this, you get into table 3, they then said, well, wait a minute, maybe there's a whole bunch of factors that contribute to this and are skewing the data so that we're not actually getting a clear picture here, because it's fine to find an association, but what if there are factors contributing to that association? Age, BMI, the dosages or the types of medications that are being used? What about your diagnosis? So they actually mixed all of that in and then came up with this table 3. And this is for live births after a fresh in vitro fertilization embryo transfer. So they did their cycle and they put the embryo in a fresh cycle right after they had made the embryo. So these are not patients that had them frozen. These are patients that went directly into a fresh cycle. So what they showed here was that there was a difference in the body mass index, first of all, between success and lack of success. And if you look at it right here, there's about almost a 9 to 10% decrease in success for every unit increase in body mass index or a body mass index over 30. So you are seeing a decrease in the success rates when your body mass index is higher. When you move further down in the data here, the days of stimulation was actually not significant. So when they compared less than 8 days, 9 days, 10 days, 11, 12, and greater than 12, they actually did not see a difference in the groups. So they're not seeing a difference in the duration when they're controlling for the dosage of the medication. But when they controlled for the dosage of the medication and the duration and all those other things, they do see a difference in success rates that's quite significant. So when you have a dose less than a total of 2,000 international units of the drugs, you had your highest success rate at about a 27% increase compared to the patients that were taking more than 5,000 units. So you got almost a quarter to a third higher success rate in live birth with a fresh transfer if your dose is kept lower. 24% if your dose was between 2,000 to 3,000. Almost 5% if your dose was 3,000 to 4,000. But once you're getting over the 4,000 range, you're really dropping off significantly and seeing a significant decrease. There, it was just 12% higher. And once you're over 5,000, that's the reference. So you're actually showing that all the other ones were a much higher success rate. Now, the neat thing about this is what happens when you do a frozen embryo transfer. So when you do a frozen embryo transfer, the only thing that turns out to be significant is your age, which definitely has an impact, small, but nevertheless significant. Your diagnosis of diminished ovarian reserve had a big impact. There was about a 30% decrease in success if your diagnosis was diminished ovarian reserve. And then when they looked at the days of stim and even the total dose, they actually are not seeing a difference in that group. So everybody's saying, well, why? That doesn't make sense necessarily. So the question is, where is the impact of that high dose of gonadotropins? Is the impact on the egg and the embryo, or is the impact on the lining of the uterus? And maybe that's why it's different in fresh versus frozen. And the answer is it has to be more in the lining than on the egg or the embryo, because in a fresh cycle, you're seeing a difference. But in a frozen, you're not. If the impact was on the embryo, it's not like freezing and thawing it is making it better. It's not going to have any alteration in the embryo quality at all. If anything, potentially it might make it worse. But on the endometrium in a fresh cycle, if you have super high levels of estrogen, you're overdriving the endometrium, and we know that that can have a detrimental impact. So if it's having a detrimental impact, that could be very significant, and maybe why, when you're going to the frozen cycle, you're doing a much better sort of cycle, you're getting better results, because at the end of the day, you're going to see that those patients will have less impact on the alterations, and we're talking about biochemical alterations, in the lining of the uterus. They're actually going to have a much more natural kind of level of everything in there. And as a result, the embryos have a much easier time sticking than they would when you've got these supercharged levels of estrogen in the endometrium. And now it's really been overexposed. So the authors basically say that the dosage is important, but only if you're doing a fresh transfer. So if you're going for a fresh transfer, you do not want to be on a super high dose of gonadotropins. You actually want to stay under 5,000, preferably even under 4,000 total. What does that mean in actual numbers? You probably should limit your total level to 300 if you're aiming for a fresh transfer. With a frozen, it doesn't make a difference. It's perfectly fine to go higher. But if you're aiming for a fresh, which we rarely do these days, you definitely want to keep your doses lower. That will give you your highest success rate, and that's where you want to be. So do not let people give you too much in terms of meds. And I would still advocate for keeping your cycle length shorter, which also has to do with the duration and the dose of the meds. You're not going to get into the 5,000s usually in terms of gonadotropin dose unless you're either taking super high doses or you're taking lower doses, but for a very long time. And so it's hard to kind of fully tease those apart. You would probably need an even bigger study to see if that was an impact factor or not. But we definitely recommend keeping your cycle length not too short, so it should be more than 8 days and not too long. We stop maximum at 12. If you're going past 12 days, the egg quality really is never very good. So you need to be super cautious. So is it fact or fiction that your ovarian stimulation dose has an impact on your cycle? It's a fact with fresh cycles, and it's a fiction with frozen cycles. So with a fresh cycle, if that's your target, and usually it isn't these days, but if for you it is, you want to make sure that you are keeping your dose reasonable. And if you are doing a frozen cycle, you want to make sure that you are just getting the best stimulation for you, but keep it a reasonable duration for sure. So thanks for joining us for the Fact or Fiction portion of the show. This will be up on our YouTube channel, youtube.com/drvictory, Dr. Victory. We have many of our other episodes there, as well as some informative videos on infertility. We have one on our saline infusion sonohysterogram. Lots of great material there for you to review. And of course, if you have any questions about anything, don't hesitate to reach out to us. So we're going to start with all the live questions now. I will stop sharing for YouTube and Facebook and those guys, and we can go back to discussing everything. So I'll start on YouTube. Liz M. Top of the evening to you too. Hi, Dr. Victory. I'm seeing a fertility doctor. I was told that my egg count is low, around 0.9, and in my mid-30s. Can IVF still be successful? So I'm not sure what you mean by an egg count of 0.9. I suspect you mean your AMH. If it's your AMH, Liz, that you're referring to, it very much depends on whether you're referring to picomoles per liter or you're referring to nanograms per mil, because there's two ways to look at the AMH level. Either way, that is probably relatively low. Is it still possible for IVF to be successful? Yes. If it's picomoles per liter, it will be difficult. If it's nanograms per mil, you have a reasonable chance. So I would definitely say there's always hope, but you need to know exactly what your levels are. You should count how many eggs you have and so on. And sometimes there's ways to make a few extra eggs, things like testosterone priming, DHEA. So that may or may not help. They haven't been proven to improve live birth except for testosterone, but nevertheless, more eggs is probably going to be beneficial. So make sure you know which units you're talking about. What is the purpose of a cycle day 2 or 3 blood work and vaginal ultrasound post-hysteroscopy follow-up? What should this follow-up show to ensure that my removed retained placenta didn't cause any impact on my lining? So we would never do that on day 2 or 3. I'm not sure who's doing that. You might just get a baseline ultrasound on day 2 or 3. Blood work is not going to show you anything unless they're looking for your beta HCG to make sure all the tissue is gone. But what you do probably want to do is a saline infusion sonohysterogram, which is an ultrasound in 3D where we can see the inside of your uterus. That will definitely show if there's any retained tissue in there, and that's what you really need to know. Although hysteroscopically, the whole point of doing it is to make sure there is no retained tissue in there. So have a look with the ultrasound and make sure. They may be able to see it with the 2D ultrasound, but kind of iffy. Liz M., you're very welcome, dear. I'm happy to help. I'm going to start with a question a patient asked me earlier in the day because I promised her I would answer it. So the question was, if you have a mosaicism yourself, and that's where some of your cells are normal for their chromosome complement, but some are not, do you have to do IVF and or can IVF be successful? So the answer is no, you don't have to do IVF. because it's luck of the draw as to whether or not the sperm or the egg, whoever has the mosaicism, is normal or it's abnormal. So there will be a percentage of normal sperm and eggs. There will be a percentage of abnormal. And so you can just try naturally. You can try insemination if you need that for any reason, but understand that your miscarriage risk would be higher than normal. With IVF, you have the ability to screen out the genetically normal embryos. So your chances are definitely going to be higher and be better. It's not mandatory. You don't have to do it, but it's very reasonable to consider because it's definitely going to improve your chances, reduce your frustration. Albeit it's expensive. So keep in mind, you've got to do your IVF, you've got to do your PGTA, but nevertheless, I think that's a reasonable approach to things. And I would strongly advise you to at least consider that option for whatever it's worth. I still join even though we finished our treatments. Always nice to watch. Oh, thank you. Nice to have you there. Hi, Dr. Victory. We miscarried a normal embryo at 6.5 weeks. Oh, I'm so sorry. Started off with a heartbeat of 80, then stopped growing. We will be doing the RLP and sono. Is there any additional testing? So I think you mean recurrent pregnancy loss, RPL, and sono. So yeah, you should always have a saline infusion sonohistogram done before you even start your IVF cycle. I'm very sorry for your loss. Recurrent pregnancy loss testing is reasonable depending on your age and so on. You can definitely do thrombophilia testing, which has not been proven to be beneficial, but I'm still a believer. Some people go down the immune pathway. It's probably not reasonable after just one miscarriage, but if you're very concerned, you can have that tested as well. You should definitely get checked for ureaplasma, mycoplasma, and if there's any history for previous uterine infections, chlamydia, gonorrhea, recurrent bacterial vaginosis, anything that may cause an infection inside the uterus, previous PID, you probably should get the uterus itself, the endometrium, tested. We use a company called Fertility out of Greece, but they'll be able to answer for you if there's infection inside the uterus or not. So that's really important for you to know, and I would strongly advise checking all of that stuff before you get started. Also wondering if histamine intolerance or terrible seasonal allergies can cause an immune reaction and miscarriage. Yeah, anytime your immune system is overreactive, you can cause a miscarriage because your immune system is not as discriminatory as we would like it to be. From the most basic standpoint, when your immune system sees the embryo, it says, oh, half normal, and then some of the cells go, wait a second, half not us, not normal, because half of it's coming from a DNA source completely foreign to you. So if your immune system's overactive, sometimes the hey, half not normal side wins and tries to get rid of the embryo. So that's the whole basic pathophysiology of it. I mean, I'm super simplifying this, but nevertheless, in layman's terms, that's the easiest way to understand it. And that's really important for you guys to know because there is no question that if you have strong allergies, you've got an overactive immune system, it may be impacting things for you. So definitely get that looked at. Okay, some friends from another fertility place are watching. Low AMH, 8.9. That's not that low. And no other known issues. Age 29. AFC is 21. If your AFC is 21, someone messed up on your AMH. 8 eggs retrieved, 2 embryos. Is this normal or did something go wrong? Something went wrong. None of that makes sense. So a low AMH, 8.9 at 29 years of age is low. 8 eggs retrieved if your antral follicle count was 21 makes no sense. And why you only ended up with 2 embryos also makes no sense. So that's from Alda. Alda, you need to contact me, get a second opinion, and I'll figure out what went wrong. Don't hesitate, and we will be happy to go over it all with you. Someone has not heard from our office. They sent the referral 3 weeks ago. Just call and leave a message, and they will be with you. No problem at all. You should have heard. If you haven't heard from our office, they probably have not received it yet. So we'll chat with you soon. Just call the office and leave a message, please. 519-944-6400. Any info you can provide for those with low AMH and doing IVF for the first time? Sure. So low AMH, and IVF are difficult. They do occur frequently. The problem is you're probably going to yield less eggs. So you only have a couple of very straightforward options. One is to use a protocol that tries to maximize the number of eggs produced. So that's things like testosterone priming, DHEA, loads of vitamins, something like a microdose flare, or a high dose approach, especially if you're not doing the fresh like we just reviewed, and you're going to do a frozen. Or if you're really very low AMH where you're only making 1 or 2 eggs, we frequently advocate to just do natural cycle IVF. There's no point in taking tons and tons of meds if you're only going to produce 1 or 2 eggs. You may as well take very few meds and have no impact on your endometrium or your egg quality. And then just make 1, maximum 2, go fish those out, make an embryo and see what it looks like. So you have to choose which path you're going down. If you're going down the full stim path, there are protocols that many places use to try and maximize the egg number and egg quality. So you should definitely have a look at that and try to make that work for you. Like I said, those are the things we talked about. Testosterone priming, some people use estrogen priming, DHEA, you want to make sure your vitamin levels are all up to snuff. Don't use anything that is decreasing your AMH. So smoking, drinking, drug use, marijuana, which is not safe. All of those things need to be eliminated. So those are the ways to help you when you're doing a low AMH IVF protocol. Hello. Whoops. What are your success rates on natural IUI, medicated IUI, and IVF? So it depends on what your diagnosis is. There's no way ever to answer these questions of success rates because it depends on the patient's age, their diagnosis, the sperm quality, their habits, their body mass index, vitamin levels, like the list goes on and on. In general, natural IUI has a relatively low success rate of about 8%. And this is based on studies. Medicated IUI, if you're using pills, is 10 to 15%. And if you're using injections, is about 20 to 25%. IVF is so dependent on your health history and your overall quality of your eggs and the sperm and so on. If you're young, we're getting as high as 80%, and if you're older, it can be very low. So it all depends on multiple different factors. We do have very good success rates, I'm very proud to say, but it's incredibly dependent on you, less so on us. It's all about the patients and what their age categories are, their weight categories, the health of the patients, all of that stuff makes a huge difference. Easier with IUI to answer. For IVF, it's really sensitive to those things. Do you adjust the gonadotropin dose if someone isn't responding early in the cycle? Oh yeah, of course. We watch our patients very carefully. So if they're not responding, we adjust as we go. And you have to do that. If you're not doing that, you're not doing the right thing for the patient. So if you're early into the cycle and you're not seeing a response, you boost the dose. If you are not seeing a response even after boosting the dose, we cancel. We do not drag patients out for a 2-week stim to find out they've made terrible eggs. That just doesn't make any sense at all. Facebook. I've had 3 failed medicated transfers with PGS tested embryos. All my tests are normal. We tried ERA and with the extra progesterone, still negative beta. My doctor wants to try a natural cycle. Is there anything that you would suggest? Yeah. So first of all, don't do another transfer until you've figured out what's wrong. And you need a lot of testing to figure that out. So I would abandon ERA. It has been proven again and again and again. Just last week, 2 more studies that showed ERA is useless. So do not follow the ERA test. It is unnecessary and not helpful if your lining is thick enough. You can definitely get your vitamin levels checked. That should be important. Make sure your thyroid is appropriate. So make sure you've got good thyroid function and levels. I would highly recommend seeing a naturopath or a traditional Chinese medicine specialist. We use Dr. Jennifer Strong here. She's amazing. We love Jen. So Jen, if you're watching, thank you for all you do. And then you should probably do that fertility testing to see if there's an infection inside the uterus. And then, of course, make sure all the other elements are there. So your body mass index needs to be reasonable. If your body mass index is over 30, you're looking at about a 40% decrease. If it's over 35, you're looking at up to a 70 to 80% decrease. So your body mass index is really important. Exercise can improve your success. Reducing stress can improve your success. There's a whole host of things that goes into this. Make sure you're taking both progesterone in oil and vaginal progesterone, and make sure that they're checking your levels to make sure that they've got the levels right. Find out if you've got day 5 embryos or day 6. There is a lower miscarriage risk and a higher implantation rate potentially if you've got day 6 embryos of using a full 6 days of progesterone exposure. So that's something to think about as well. I'm sorry you're having such a hard time. I'd be happy to go over your history with you again. Just reach out to the office, make an appointment, and I can review it all in detail, but do not do a transfer till you get more answers. 3 failed PGT tested embryos really doesn't make sense. So that's a case where you definitely want to make sure you know what's going on. Hi, Dr. Victory. I have PCOS, had 1 pregnancy on letrozole, ended up in miscarriage, got pregnant on my own and ended ectopic pregnancy. Just did my first IVF and had a blighted ovum. Oh gosh, I'm so sorry. That sounds like there's more to it than just PCOS. So you need some answers, and I would definitely go through everything in detail. That's a lot of history. The ectopic, I would want to know again if it's chlamydia, gonorrhea related. Was there a problem with the tube? Do you have hydrosalpinx and so on, which can also result in miscarriage or failure? And you need your egg quality tested. Again, eliminate all the bad stuff, smoking, drinking, drug use, get your vitamin levels up high. But if you have PCO, you should have a lot of embryos. So hopefully it's just a matter of trying again. Nevertheless, I do always recommend you dot every I and cross every T before you're doing your fertility treatment so that we make absolutely sure that we're not wasting even a single embryo, even if you have many of them. So make sure you get checked out by whoever's taking care of you. Would this fact or fiction result also apply in a microflare or CAP protocol? Not if you're doing a frozen embryo transfer. So if you're doing frozen, it doesn't matter. And most of the time when we're doing a microdose flare, those patients need to have PGT testing. Not always, but in many instances they do. So if that's the case, we normally will be doing freezing. In most cases where we do use a high dose of gonadotropins, we're freezing anyways. It's very rare for us to do fresh embryo transfers. So hopefully that answers that. I don't think this fact or fiction is relevant to a microdose flare unless you're doing a fresh transfer. How many days off would you need for egg retrieval? If you mean after, usually 1 or 2 unless you're producing a ton of eggs. If you're producing a ton of eggs, then you might need a little bit more, especially if you get mild hyperstim. Normally within a couple of days, you're feeling pretty good. Question from YouTube with the ectopic pregnancy and the blighted ovum and so on, just said she had 22 mature eggs. So I need to know how many embryos you had, but with 22 mature eggs, you should have a very good outcome, dear. So I would not be worried, but make sure you get answers before you go through with another transfer. Does the recurrent loss panel, oh, that's what they meant by RLP, okay, need to be done when period returns, or is it okay to do it while waiting after a DNC? No, you definitely need to wait to do your RPL workup because some of the things we do, like a thrombophilia screen, will be altered because of your pregnancy. So wait at least 6 weeks before you do the screen. That's really important. I'm losing my voice. Thank you for the hot tea, Tar. I presently have 0.56 nanograms per mil on my AMH level and currently producing up to 4 follicles on IUI. We'll be trying IVF. Do you think there would be any issues? That's a low AMH. It's quite a low AMH. So you will likely have issues, especially if you're only producing 4 eggs. There is the possibility that it will be difficult to succeed with the IVF. Doesn't mean you can't. It just means that it will be more difficult. So be prepared to try more than once. That's important. What is the approximate cost for IVF? So we have different IVF packages. Our lowest is just $6,000 for natural cycle IVF. These are Canadian dollars as well. I think that's about $50 US these days or something like that. So 6,000 Canadian, all the way up to around 23,000, where we offer a money back guarantee and include the meds and all that stuff. So for patients that want hassle-free, we charge a little bit more, but then you get almost all of your money back if it doesn't work. For patients that just want to pay individually, least expensive about 6, average probably more about just under 10,000, and then your medication costs. So that's roughly what's being charged for the IVF. Hi, Dr. Victory. I'm waiting for an appointment with you beginning of November. Oh, great. Had a failed transfer in August. Wondering if there's anything I can do in the meantime to prepare for my appointment. You got to do your camera thingy. So yes, there are things you can do to prepare for your appointment, but they're mostly just lifestyle things. So you want to definitely have your exercise in place. You want to be eating healthy, 3 meals a day. You want to have Mediterranean diet. Get rid of everything bad, because I'm basically going to lecture you when you get here if you're doing anything bad. So no smoking, and by no I mean zero. No drinking, no marijuana use, no vaping of anything. Squeaky clean. Take vitamin D, because we will check your levels, and if they're low, we're going to give you vitamin D. So all of that's really, really important. Do I have any satellite clinics in Toronto? Actually, I work at Create in Toronto right now, and we're about to open up, or at least join forces with another place that's going to become a satellite of VRC. Yeah, by end of the year, we'll have 5 locations and possibly some more after some negotiations tomorrow night at dinner. So we're working really hard to get that all organized and grow our little practice into a not so little practice. So things are going really great. We're really happy to have partners on board. We do tend to focus on some of the smaller communities, but I do have a practice in Toronto. So just reach out to our Windsor office and they'll book you to see me in the Toronto office. No problem. I'm there usually once a week or so. Is DHEA safe to continue while preparing for an FET? Wondering if I should continue it in case I need to do another egg retrieval. If this FET is not successful. Yes and no. It's safe as long as you stop it before the FET. But then you're going to be waiting 2 weeks, during which time you're not on any DHEA, and then you're going to lose the benefit because you are supposed to use it for a minimum of 3 months continuous. Keep in mind, DHEA has never been shown to improve live birth rates. So we still use it occasionally, but I don't actually think it makes much of a difference. You might get 1, maybe 2 extra eggs. I've never seen it actually alter the course of the cycle for someone. So iffy at best, and I wouldn't use it before an FET cycle. You're probably not going to benefit from that. Do you do testosterone priming with microdose flare protocol? How long do you prime with testosterone? Most people start around cycle day 21 of the previous cycle. And yeah, we use it with microdose flare all the time. That's a very reasonable thing to do. Amy on Facebook. Is it safe to take Champix while trying to conceive? Dear God, yes. Please take Champix. It is way safer than taking any kind of nicotine substance, especially smoking. So for sure, take Champix. It's a good product, has a 72% quit rate. Make sure your partner quits smoking if they're a smoker as well, because when you have one person smoking and the other one is not smoking, the one that stops smoking will always go back to it if the other person doesn't. So in a partnership with someone, you got to make sure you both quit smoking, not just you alone. You're welcome. That was a quick response. If you have low AMH for your age, 31, but all other labs and tests are normal, is low AMH the infertility diagnosis, or is it unexplained? Low AMH is not a diagnosis at all. Just because you have low AMH does not mean you can't get pregnant, or else no one over the age of 40 would ever get pregnant. So That is not a diagnosis. If that's the only thing they found, it may reflect a problem with egg quality, which you can't know unless you extract your eggs and look at them. But it's definitely not a diagnosis. Low AMH is not a diagnosis. It's a condition, but it's not a diagnostic test. It's just a warning sign that you need to hurry, or that we may not do as well with the yield of the number of eggs as we would ideally like. I had 3 medicated IUI and planning for the 4th this cycle. Wanted to speak to before any treatments this cycle. However, latest availability was middle of the cycle. Anything you can do to help expedite? I'll write your name down and I'll ask what we can do. Okay, I got it. So I'll see what the girls can do. Otherwise, just hold off for a month and we'll get to it the next cycle. That's not a problem. Do you recommend weaning or stopping cold turkey on IVF meds, taking estrase, PIO, and suppositories? I'm not sure I understand that question. Do I recommend weaning or stopping cold turkey on IVF meds? Do you mean if you are not successful, you can just stop them all? You do not need to continue your IVF meds if you were not successful for a frozen embryo transfer or a fresh embryo transfer. There is no need to wean. No one's ever looked at that at all. So make sure that you just stop. Yeah. Is it pointless to do NIPT if the embryo is PGTA normal? It is not pointless. The error rate with PGTA is higher than the error rate with NIPT. So if you're worried, which I wouldn't be, you can do the NIPT. NIPT has a 1 in 10,000 failure rate. PGTA is a little bit less than 1% typically, depending on which platform is being used, or around 1%. So, I mean, there's a big difference, but if you're worried about a 1% issue, yes, go do the extra testing. If you're not worried about 1%, don't. I don't normally tell my PGTA patients to do NIPT though. Good evening. I changed my prenatal pills from the ones I was taking morning and night due to making me feel sick. I am having my transfer next week. Is that fine? Thanks. It's totally fine. Don't worry about it. Any prenatal is good. We like PregVit Folic 5 because it's very strong. It's got high levels of everything, but it's not mandatory, and you definitely don't want to be queasy when you go into this because you'll be even more queasy when you're pregnant. So it's perfectly fine. Any prenatal pill will do. Just make sure you're getting iron. Here are the 4 keys, right? So you need iron, you need a decent prenatal, you need to have your omega-3 fatty acids, and you need to have vitamin D. And the reason I say iron is there is a study coming out, which has not been published yet, which demonstrates that your serum ferritin level is directly correlated with your success rate. So we're now going to add ferritin to all the other tests we've been doing. It never ends. And Ash, I'm sorry it made you sick. My last RE refused to adjust gonadotropin dose. I've already made the switch to you. Oh, well, I'm glad you're with us. We will adjust your dose on the fly if we have to. What do you find to be the reason that IVF doesn't work on the first try? Oh my gosh. We would need about 6 weeks of time to go through all of that. So it's either the passage, the passenger, or the destination, I always say. So the passage is the technique of putting the embryo in. So if it was a bad embryo transfer, if the location wasn't good, that's certainly a possibility. If it's the passenger, it's the embryo, so lack of energy efficiency, genetically abnormal, didn't have all the right proteins and enzymes to do its job. And then the destination is the uterus. So is the lining good? Is the progesterone level okay? Is the immune system functioning properly? Are you smoking, drinking, using drugs? Is your hormonal milieu okay? Is your genetic makeup okay? What's your body mass index? Do you have bad habits? So there's a million things that goes into that question. It could not work on the first try for any one of those, but the 3 big categories I always explain to my patients is the passage, the passenger, and the destination. So any of those could be the possible explanations for why it's not working on the first try. Why is IVF so much more expensive in the US? Truly impacts access. I would love to say I have a simple explanation for that, and I do. Don't say it. I'm being told not to say it. So, it's definitely driven by business in the US. And they have bills to pay, and they have a lot of people that they need to hire to do the work that they do. As an example, I do not have someone here who we ever had to hire independently to go chase insurance companies down for money, because we're not billing insurance companies. We have one person that does all our billing. She happens to be my better half. And so, we've never needed to have like a whole division dedicated to chasing down insurance companies. And so it's a little bit easier here. Plus, my goal is to help people. My goal is not to become rich or famous. So if I get a chance to help you, that to me is worth more than any monetary, compensation. And so I think it depends on the goals of the people that are helping you. If they're aiming to build a big business, that's great. That's what they want to do. That's wonderful. But that ends up costing more for sure. If their goal is to help people, I try and keep our costs low because I want to help people. So we are intentionally keeping our prices as low as we possibly can. And I believe we're the least expensive around in order to help more people. And that's why we wanted to set up on a border city so we can actually get a lot of the Americans over, because it's so much more expensive in the US. It's like 3 times the price of what we're charging in Canada. It's just totally unreasonable for a lot of people there. Please open clinic in Calgary. Hi, Mac. That's very sweet of you. Calgary has a good program. The Regional Fertility Program in Calgary is a great program. I will probably eventually start moving out west with our business model, but it's going to be a while before we get there. And you may see me running in terror from my family members who want to kill me by that point in time. So let's see what happens. What effect does extremely low vitamin D level have on male sperm? Low count, poor motility, poor progression, higher number of abnormals. Virtually every aspect is impacted. So it is definitely important to have normal vitamin D levels in men, and very important in women. Critical, critical, critical. Make sure you do it. I am in BC. Can I still get consultation from you and come over for my treatment? Yeah, absolutely. We've treated people. I've got one patient in Japan right now. We've had patients in Israel, innumerable patients in Europe. We do a lot of work with patients from all over the world. I have one from Lagos, Nigeria. So yeah, we work with people all over the place. Certainly anywhere in Canada would be easy. We'd be happy to do the consult and then take care of things. So don't hesitate to, just call, make an appointment, or you can email us at info@drvictory.com, and we will set up a consultation with you and then help you out for sure. Did you pick the best rated embryo for transfer for the first FET? Yes, we always pick the best rated embryo for your first FET. That's a total no-brainer. That's the one we're always going to go with. My DHEAS was 1,539 nanograms per mil. Oh, we use different units here. Should I be taking DHEA supplements? Again, I'd have to convert your units, but DHEA supplements don't actually do anything. They put hair and acne on you, but they've never been shown to improve live birth rates. So use with caution. It's not really a very helpful thing to use. So it's, for some people, it might make them make 1 or 2 more eggs, but the problem is 1 or 2 more eggs that don't translate into a live birth haven't done anything for you. So you got to be kind of careful with that. Does it make sense to do PGTA with 3 embryos obtained? Oh, that's my cutoff number. Great question. Fantastic question. So the answer to that is it depends on your age. So first of all, if you're less than 38 years of age, do not do PGTA because it's been proven to be useless. So unnecessary if you're less than 38. If you're over 38, probably about 60 to 70% of your embryos automatically at 38 are going to be genetically not normal, abnormal. And so what you really need to calculate is you've got 3, you can estimate that at least 1 is going to be abnormal. So what I always tell people is you need to think about what your next step would be. If you put in those embryos and God forbid, none of them worked, your question, if you haven't had them tested, is, well, were they normal or not normal? If you're unwilling to ever use a donor and you're just going to keep trying yourself, you probably don't need to get them tested, because if you're only sticking to you, what's the testing going to do for you? It'll reduce the number of embryo transfers, but it's not going to change what your outcome is going to be. You're going to just keep trying until you're successful. But if you're willing to consider a donor and you make no genetically normal embryos, which is possible, especially when age is a factor, then yeah, you should get tested, because if you find out 1 or 2 cycles into it, you've produced no genetically normal embryos, you really need to consider whether or not it makes sense to do it again. So I think you kind of need to know your pathway forward to make a rational decision, and then do the PGTA based on that, but don't do it if you're less than 38. Not a single study shows a benefit, so don't waste your time with that one. Does taking meds for IUI, letrozole, estrase, permethrin, impact the efficacy of hypothyroid medication? It can, not the letrozole or the permethrin, but the estrogen can. So make sure your thyroid is being checked while you're going through your cycle. And we always check everybody before, so make sure you're getting checked appropriately. Someone's asking again, what do you suggest for those with low AMH to increase success with IVF? I answered that earlier in the show. Just watch things. My clinic at, I think, Create makes metformin gel at their clinic. Metformin gel? How effective is this? I have no experience with metformin gel. I'm not sure why you'd need to take it as a gel. Metformin should be taken orally. I don't know anything about metformin gel. I've never even heard of it before. I'm not sure why they would be doing that. Hi, Dr. V. Fingers crossed you one day get funding for your IVF clinic. I think we will. If so, would that speed up the wait time for people in the IVF wait list? It would hugely speed up the wait time. So I think hopefully, God willing, everybody say a prayer, we will get funding for our IVF clinic. I'm very hopeful that the government will come through with us, for us. We've had some very good discussions, and hopefully this Thursday we're going to have some more. Tarek, are we having more this Thursday? Friday. So we're working on it. We're trying very hard. We're pushing all the right buttons. People know about us. They know about our requests. So hopefully something will come to fruition with that. But I don't know. We have to see what they say. It's a possible yes. It's a possible no. It all depends on what they say. Certainly, if they give us what we asked for, we could clear out our wait list in about 1.5 years. So I think we'd be in very good shape, maybe 2 years, keeping in mind that we are going to be servicing northern communities who can get to us. We're going to be servicing Sarnia, Leamington, Chatham, Essex, and Windsor. So there's a lot of areas we're going to be covering, and hopefully at some point in time, London as well. So, we would have to see how it all pans out. But yes, we would definitely be reducing the weight. If my AMH 20, can letrozole helps me ovulate? I do have PCOS. If you have PCOS, letrozole will help you ovulate for sure. So take letrozole, and on our website, under the resource tab, we have this great little map of what you should do for the letrozole. So www.drvictory.com. Go there and check out our website. Go to resource guide tab. There's a really neat little flow chart made from a very special young lady for us, and it shows you what you need to do. Hi, Dr. B. How long does estrase take to start making a difference in the uterus lining? Anywhere from instantaneous to days or weeks, depends on your lining. Easy question. Does growth hormone reduce the length of the stimulation? So human growth hormone can reduce the stimulation duration. There are a couple of studies that have shown that. More importantly, it actually can make a very significant difference in the number of eggs, but there is only one study that has shown a difference in live birth rate, and then a more recent study said it did not make a difference in the live birth rate, and it was a big, well-done study. So I think the jury is out again on human growth hormone. But if you're just trying to tighten up your duration, it may work. I've never used it for that purpose. It's really expensive, but it could work. What does genetically abnormal mean? Does the test show what kind of abnormality? Yeah, so if you're doing PGTA testing, it's going to tell you if you have 23 matched chromosomes, 22 autosomal, and then the sex pair, which is XX or XY. So you'll know if you have an extra chromosome or a missing chromosome or whatnot. All of that's there. Does NT blood work testing determine gender? NIPT blood work testing determines gender. NT testing is nuchal translucency, and that blood test is the one that goes with that does not determine gender at all. Hello, good morning, Sir Doc. Hello and good morning, Sir Doc. If I had a low AMH level come back, do you think testing a second time would help to see if that number changes and could have come back wrong the first time? Yeah, there's no harm in trying a second AMH level. There's a very reasonable chance that you'll get a good result from that. So there's no reason why you can't try checking it again. It depends on what your history is. If you're 43 and you have a low AMH, you're going to have a low AMH. But if you're 22 and you have a low AMH, then that doesn't make sense. So you should get rechecked. Also get an ultrasound to complement it so they can count the number of eggs, and then you know exactly what you're dealing with. How do you deal with fluid in the uterus? That's a great question. So if you've had a previous cesarean section, they need to check you for something called an isthmocele, which is a defect. It's if your uterus kind of goes like a fish, it's a steeple-shaped defect at your C-section scar. So if I draw a picture for you, the inside of the uterus looks like this. Hopefully you guys can all see this. So that is an isthmocele. So if you have an isthmocele where your C-section scar is, then you need to burn it or they need to remove it and fix it. That can be producing fluid. Otherwise, you got to look for infection. And again, for that, these days I am sending everybody to Fertility. So www.fertilys.com. I don't own any stock. I have no relationship with them whatsoever, but they do a good job and they have a good test. Not the cheapest thing ever, but it works and it's effective. So I would strongly recommend you consider that. I know your name for the last page in writing, so I got that. I think we ran out of questions, folks. So that was a great show. I appreciate all the really wonderful questions. So we will be back again next week, I think Monday, with another great show. And I am hoping to be able to come up with a great topic. The papers are getting a little sparse, so we are constantly looking for good topics. If you guys have one that you want me to review, let me know. I will be more than happy to review something that you all want us to review, and maybe we'll put up a poll with a couple of different options and see if there's something specific. No, you haven't run out of time. Ask if you have a question. Hello, Doc. We got 2 minutes. I have a question. If have myomas, that's difficult to pregnant. If you have fibroids, it can be. It depends on where they are. It's depending on size and whether they're distorting the inside of the uterus or not. So if they're distorting the inside of the uterus, for sure it can have an impact. M-No-X, if you have a question, you got 1 minute to ask me. And thank you to everybody that's saying God bless you too. How about polyps? Yes, remove your polyps for sure. If you have polyps, you must get them taken out. It is a almost 100% increase in your miscarriage risk. Okay, we're at 8:59. Anybody that didn't get through to me on Instagram, you can always DM me and I'll usually answer. And for those of you watching on YouTube, thanks for joining us. Facebook and Twitter as well. I hope you all have a great night. Enjoy the rest of your evening, and we'll see you again next week. Take care, guys. Bye. How can I learn to trust the process of IVF? message me because we're going to run out of time and they're going to kick me off. We'll talk soon. Bye.